I'd like to welcome everybody to Exocad, the basics of Exoplan, presented by Kevin McAuley. Kevin's been at the lab for now, I believe it's been 2 years. He's a director of technical and strategic developments in the lab. Before this, Kevin was with Nexus for about 2 years, and then before that, he was with Henry Schein. Before that, he was with Noble Biocare for almost 20 plus years, and as I go all the way back, he started out with Roadsark Dental Lab on his dental journey. So we're really excited to have Kevin back. And Kevin, please take it away.
Thanks for joining us today, everybody. We're going to take a little walk through the workflow as well as some of the background on implant planning and guided implant surgery. With a lot of the day-to-day, not just in my previous life here at Roadsark, but also with Noble Biocare, I had an opportunity to be involved in the evolution of both planning softwares as well as guided surgery kits. And when I look at what we do here day to day from a planning perspective and surgical guide standpoint, we thought it would be good to continue to update everybody on the different options that are out there, as well as also the possibilities in what you can do with cases and how you can plan ahead. And often it's patient driven to need to do something immediately. But I will talk about some of the same day options, or what we call just in time solutions for patients. So, I mean, I've had these photos for a number of years. The one on the right always makes me laugh. And I use it as a more in perspective that everything we learn today, comes with instructions for use or comes with some sort of quick start. And the quick start only has the, how to turn it on and get moving. There's always more instructions that go with these different types of things that we do on an everyday basis. And everything I'm sharing with you today, is a compilation, is really a smattering of a number of different companies and their guided surgeries, as well as even on the implant planning side. So bear that in mind. Whenever you're looking at doing anything from an implant procedural standpoint, anything involving surgical kits, everything is related to the implant specific company that you're working with, as well as the representatives who are there to work with you. They're there as guidance often, but again, those instructions for use are, at the end of the day, what is so important for you to be aware of, and your team. If we have some assistants on here, or some surgical staff, that are working with doctors, often in some of my past experiences, you would know more on the specific components than the surgeon themselves, and you, of course, hand them in a timely manner. So bear that in mind with everything we're talking about today. The company specific instructions are the first go-to for you when it comes to step by step. And, even from a laboratory perspective, they keep us up to date, but we're never, up to the minute when it comes to these different solutions. So, and I've used this slide before, but it's one that I always find interesting. If you look on the left, it's essentially everything that now is packaged in our phones on the right, plus. That was just a video camera system in the early days. So obviously things are getting more efficient and getting a little more predictable for all of us. And of course, adding a lot more complication in some ways, or distraction. So when we look at, why do we want to look at case planning? Why is this something that we want to do up front? You, of course, treatment plan every patient. You treatment plan every solution for a patient that comes in the door. If we look at traditional implants, and by that I mean from the 70s and 80s, as the early days of their evolution, the implants were placed essentially wherever the bone was under a certain protocol, and then you dealt with it from there. And what might be interesting to you is, the second patient at the University of Toronto in the 70s, they had placed 5 implants, but the one in the middle was angled such that they couldn't use it. So in fact, it's been on implants of 4 implants, and my understanding is they're still functioning on them, So you talk about how many implants that have been required. 5 was considered the standard of care at the time, the protocol. But that patient was functioning on 4 because we didn't have angled components. We didn't have the various laboratory solutions we have today. The photo on the bottom is actually involving what they call zygoma or zygomatic implants. You'll see more of these, or Z fixtures, that some of the newer companies are using as their term, but they're anchored in the zygomatic process and they emerge on the palate. The techniques are getting better, where now those screw access holes are more in the teeth. But again, we had to just deal with whatever was placed back in the day. We still even see here in the lab, we have a single central where the implant is almost 5 millimeters palatal to the envelope of the crown itself. A challenge, but it's one that, we'll work to, obviously, but it's avoidable, in that case. And, it's a challenge. Obviously, it integrated well, because those ones always do. But again, if we pre-plan, we can get better results in the end, and often save complications, but also control pricing. So how long have we been doing, guided surgery? It's been around really since the 70s, when they did something called the mandibular staple approach. That's what you see on the X-ray and the Panorex on the right and the lower. It was really a jig system where they would do an external incision, and a jig would be placed over the mandible, and then drills would be positioned in this guide or jig. You drill through, and then it would become an overdenture with a soft liner retained on 2 ball abutments. And these functioned for many, many years, but they weren't integrated like a tissue attachment that we have today. They were a mechanical fixation, but the guidance was already there at that point. And then when we started working on things like teeth in an hour, this was a concept launched back in the 90s. And again, what they were trying to strive for was same-day teeth. Now, this lecture isn't, just about same-day teeth entirely, but it's to give you an idea that a lot of the evolution and the complications and also the workflow, I would call it streamlining, has already happened. You don't have to go down a new road where everything's a surprise. I won't say it's all been done before, but for the most part, it's been experienced before. So when we start looking at, okay, I've got a case coming up, let's use a single central as an example, or a lateral. We want to make sure that we have ideal placement. Where do we go from here? And we do a number of different designs for surgical guides. I'm going to talk about a digitized or digital workflow primarily today, but we also do what we would call analog surgical guides, which could be vacuform type guides with a denture tooth in place. It's more of a prosthetically driven surgical template. So the surgeon knows, where you want the screw hole to come out. However, there's no bone data from that. It's really just on a model. So hopefully there's enough bone, and the surgeon, of course, will assess that, or yourself if you're doing the surgery. So, but we do those every day. As a bare minimum, it's giving some guidance to the surgeon as to where the envelope of the tooth is and where we want that implant to be placed. Okay, so let's get back to the digital side. So the 2 things that we really need for the implant planning service, well, really one, I can make a start with that and our team here, but the cone beam CT is the minimal data that we need to start with. And by that, I mean the multi-slice data, the files that are acquired through that cone beam CT process, or regular CT, but primarily cone beam CT in our world. And we can then import that into Exoplan and be able to create an implant plan and share that with you immediately. The turnaround time is fairly quick with that, but we're able to then give you at least information. So if you have a consultation coming up with a patient, we can give you the yes, no, what implants can we place for the discussion with the patient. Then if we want to go to the point of a surgical guide, so something that either fits on tissue or fits on teeth, when they fit on teeth, like a night guard or a splint or an Essex, if you will, this is far more predictable or repeatable than necessarily on soft tissue. And I'll talk about that technique in a little while. But what we need to create, or what we require to be able to create a surgical guide, is the surface scans of the teeth. So either an intraoral scan, which is the most common way we see it today, or we just need either an impression, or we need master casts or diagnostic casts of the patient, and we will digitize them. And then what we do then is align them together. We actually connect them, or what they call matching, of those two components, and I'll show you that in real time. But once we actually import them, that then gives us the tissue positions, the tissue contours. It gives you the actual teeth, so we can actually do a diagnostic setup of the edentulous spaces and know exactly where we want to go when it comes to the final restoration. When we start looking at the on tissue side, so envision a patient that is fully edentulous. They have a denture, or one recent one, they didn't have a denture at all. But what we need is something that will fit onto the tissue, just like a denture, so that we have the tissue compressed, if you will. And that is then scanned as part of that cone beam CT scanning process. And I'll show you more in that. But what that gives us then, because I don't see the tissue in a cone beam CT, we can approximate, but it's not a one-to-one perfect match like we see when it's on teeth. Hard tissue is easy to align to, but soft tissue is more of a visual alignment. So there's markers that we use, essentially just spherical ball markers that are on the denture, so that we can relate the two when we line up everything in the software. So from a surgical perspective, there's different approaches that you can take when it comes to guiding the drills for your site preparation. The first being a straightforward pilot guide. So most implant systems that have evolved from the original Bradmark protocol, they all have a 2 millimeter drill or a 2.4, 2.8 drill as their first drill. Right. So what would happen in the sense of a guided pilot drilling template? You have a 2 millimeter sleeve that's in that, and I'm going to show you an example of that. That 2 millimeter sleeve is there just to do your initial surgical drilling. So that gives you your trajectory of the implant path, so the drill path, and your depth. So from a safety perspective, you know where you want to go, you know how deep you want to go. And then on the top row, you then follow along with your traditional drill kit. So say you decide to do guided surgery, but you don't want to invest in the full kit, right? And those kits can be overwhelming if they're complete and they've got everything for every implant you may ever use, or there's introductory kits where they've just got very straightforward series of drills. It doesn't have every drill that you may ever need. And with that, you then do your placement or your drilling preparation and your implant placement as a freehand surgery, if you will. So just like you would when you're placing every other implant. The difference here is it gives you that trajectory and depth that was planned in the software. It gives you that predictable relationship, or transfers the plan to the patient. Okay. The alternative to that is when we do fully guided, we then have sleeves that are large enough in the surgical template where the implant can pass through. So why do we do that? Well, while using a series of what they call drill guides or spoons, depending on the seminars you may be in, there's different terms that people use, but it's really called a drill guide and a drill key, where it fits into those sleeves. So imagine the sleeve is large enough to put an implant through, but if I'm taking a 2 millimeter drill, that 2 millimeter drill isn't guided unless I put a washer or some sort of a sleeve in place. And you'll see that in an animation shortly. But it allows you then to step up through the various drills while using these varying drill guides to step up for your bony preparation. And again, depending on bone quality, you'll adapt to which drill diameters. And then your final implant placement, depending on the system, is fully guided, meaning the implant mount, which is holding onto the implant because we don't want it to unscrew. It's held on there like an impression coping. And then as you put the implant into place, it then bottoms out on the template. So it actually shows you where your planned depth is. And once that's all placed, you then remove that implant mount and either place a healing abutment if that's the approach you're taking, or look at doing some sort of a provisional if that was the treatment plan. So question I always get is, how accurate is it? Right? If you envision that the drills that you're dealing with, think of it as a hockey stick. The farther apart your hands are, right, the more stability, perhaps accuracy, but the more stability and control of the end of the stick that you have. So when we're drilling with a surgical template, the top of the sleeve is 10 millimeters above where the implant connection is. So when you're drilling and you contact bone, there's a 10 millimeter space there, and then you have the drill that's going to drill the site. So with that in mind, by having the 2 points, contact on the bone, and there's an initial drill that helps to center punch or drill punch that first spot. But as you're drilling, as you go down, there's a potential for about a millimeter of, I'll call it wobble, but a millimeter of trajectory change when it goes in. This is a known fact. And it's in the planning, we actually have a safety halo around the implant of 1.5 millimeters. Right? We want to have 3 millimeters between 2 implants, or 1.5 millimeters of bone between an implant and the teeth. Otherwise, we can't maintain bone. So that's why this safety zone is there. It's not just for placing implant to implant, but it's also making sure that we're away from any vital structures. Right? We're not radiologists here. We're just software navigators. So we have our tools to keep us safe, but then of course you can have a look at the plan from there. So when we talk about accuracy, this is all dependent on the fact that the surgical template sits passively on top of the teeth, in this case, or the soft tissue. We need that repeatable from what we used from the scans that we received. We need to be able to transfer that to the mouth. So the bottom line is, you're looking at the apex of the longest drill, which can be up to 20 millimeters. The apex of that could be a millimeter out, meaning it could be in a cone sense, but slightly out from what you originally planned. They're much closer than they were in the earlier days. The precision is very, very nice with these. If you see something like you see on the bottom, or we get a call, well, I did the surgery, but my implant's a millimeter above the bone, which is not what we planned, then in that case, we have to wonder what happened with the surgical guide, right? So from a quality control perspective, we make sure the guide sits on the model that we've replicated or we've been utilizing. You still need to do a trial of that surgical template before surgery. Make sure everything seats, and we'll give you windows to verify that it's seated. But it's really important, because then, of course, if that surgical template isn't fitting on the teeth, then we're not going to be able to predict the delivery of the implant. And in some of these implants where we're dealing with a 3 millimeter diameter implant, we're right beside tooth roots, right? So that's why we want to make sure that that's predictable. So from a workflow perspective, as I mentioned, we start out with the cone beam CT. We get some intraoral scans from either in the office or share the models with us, and then everything gets merged on the computer as we go forward. So I just want to share with you an animation. So this will walk you through, and I will fast forward some parts, but this will walk you through the different approaches you can do from a surgical perspective. So, right, we've done our pre-planning. We know where we want to end up, right? We may even do some contouring of the soft tissue on the model, right, for the case. The surgical index essentially is Blue Moose, but it's like a bite registration. You don't have to do them in all cases if you have a nice stable seating of the surgical template. Sometimes we use anchor pins. So this anchor pin is a 1.5 millimeter drill that goes in laterally away from teeth, of course, vital structures, and away from the implants. This is just there to lock everything in place. We tend to use these when we're placing 3 or more implants, or replacing, say, 4 or 5 teeth, where we don't want the surgical template to capsize when you're doing the surgical steps, right? So in this case, this happens to be Nobel, but a lot of the companies are very similar, where you use a tissue punch, either a manual one or machine. You can do a mini flap which means you'll just expose a small amount of the bone. So rather than doing a major flap. Right. Trying to do a minimally invasive approach here. Right, or you can do a flapped approach. Right, the thing to bear in mind there, and we do keep this in mind when the design is done, but if you are going to reflect a flap, we'll try to design the surgical guide where it won't interfere, where it's going to give you some room. So once we have the surgical guide in, this is what I was describing as the drill guide or the spoon, as it were. Some systems have handles or they're longer drill guides, but the whole intent here is that the outer circumference of this drill guide fits into the sleeve, because remember, we're going to place an implant all the way through this, but the inner diameter is stepped up through the varying drills. Remember, I mentioned that the top of the guide sleeve is 10 millimeters from where the implant head is, right? So the intention, and I joked about the hockey stick, but the intent is that there's 2 points of contact. If you just had this at bone level, you would have no way of predicting the trajectory of your drill. So then, depending on the implant system you're using, this happens to be a tapered implant. Most implant systems actually use straight drills, but you're just stepping up gradually, and then the target is to have an osteotomy a millimeter smaller than the implant size. All right, and that way you can actually compress the bone a little bit when you place it. But you'll see with this drill, the final drill actually has the same diameter as the sleeve, so it then dictates where we're going to place it. And then if it's dense bone, then you'll go in with what they call a fine preparation drill or the final site drill. And all that does is just take out the steps from the varying drills to make sure that the implant seats. And then you may or may not use a screw tap. I think screw taps are fairly rare these days unless it's really dense bone. We can go in if we're subcrestal. There is bone mills that are used just to go in and profile the bone so that the healing abutment will seat. This is something that we experience quite often where, we've designed a crown, but the crown won't seat all the way. And it's mainly because there's remnants of that bone that are interfering with the components, right? This one has a little bit of a flare to that implant mount. And if that rides on the bone or impacts the bone, then it holds it up. Right. So then depending on whether you have already had a bridge produced, so say you want to temporize this particular patient, we can design that in advance, but then what you'll have is a bridge with some cylinder holes in it, and then you do the dentistry at the time of surgery, meaning you attach that temporary bridge over and connect it with the implant components that you'll use to connect it in place, right? So, with this, and the accuracy that we're fighting for, we can predict the depth, right? That trajectory can be slightly off, and slightly off can be, 1 or 2 degrees, which is the difference between passive fit or not when it comes to a bridge. So what we don't do is we don't fabricate the bridge with the cylinders in place if it's done in this approach. I'll show you another one later. And then the provisional restoration is, again, already pre-milled. We usually give you wings on the adjacent teeth so you can line it up. Okay. So, when we look at the data acquisition of what we need, if you want to send a case into us, right, what we need is the CBCT of the patient. And again, as I mentioned, it's the multi-slice DICOM, right? Without a viewer. Some of them get packaged with a viewer when they're exported. If you're working with CanArray, just email us. We can log in to CanArray. You just share the case with us like a referral, and we can then go in, pull down the DICOM from that patient module, as well as scans, if scans were provided there. Otherwise, you send them into RoadSart through the regular channels, right? We'll also do a diagnostic wax up, and then the restorative plan, of course, which is communication back and forth, usually via email, so that I have all the information. But I'll ask you what your plan is and what your surgical kit is, right? What are you using? What system? And it's important because in Exoplan, just like any of the others, they're only as good as the information that the implant companies provide to us. And we call them libraries, but the libraries of the different implant systems, and especially with mergers of companies, and recent combinations of implant systems between two companies, our libraries aren't always up to date. So we may not have, whatever sleeve you bought yesterday or whatever surgical kit you bought yesterday, but it's rare, but we need that information up front. And then we can, of course, plan it for you. And then the initial plan, we'll look at the different implant positions based on the plan. And again, what your expectations are. If we do a plan for one implant in a patient, but there's other edentulous spaces, we'll often plan it anyway, just so you have options and you can talk to the patient about those other spaces. We've been asked to do that sometimes. But of course, we look through all the various tools that we have available to identify the best placement for the implants. And then if you decide to go restoratively driven, meaning you may want to do something on an immediate perspective, but we'll do that anyway in the sense of we always do a prosthetic design, and I'll show you how that's created. But we can pull that into the design software, determine exactly where the ideal setup is, just like setting denture teeth, but virtually. And we can then determine also the components that might be required from there as well. And what I like about that is we can make the quote, the estimate for the case far more accurate. And an old problem of years ago was we would always, and I don't mean we, RoadSart, everybody would add $500 just in case. And that can be the difference between a patient being able to do the case or not. And the more predictable we can make it, the better it'll be. And then implant immediate loading, I touched on it with that other case. Immediate loading or immediate function, which is the marketing term for it. But immediate loading is really often patient driven or indication driven. Their teeth are showing, or in the case of all on 4, all on X, I'll show that a little bit later. The patients need teeth. So what is that, right? Is it a denture? Is it, screw retained teeth? How are they going to leave at the day of surgery? And from immediate loading, for those of you that don't do the surgery all the time, when the doctors place an implant in, and I jokingly refer to IKEA furniture, when you work on different components of the furniture, there's different screw types, right? There's fine machine screws for certain things, and then there's screws for dense bone or dense wood, where they've got more rounded threads and they expand it to get better retention. So with the implants, it's really not that much different. The implant designs, and you'll hear about BLX, you'll hear about Noble Active as well, but those implants are more like augers, where they're designed to go into softer bone and really grip. There's a learning curve to those, but they grip really well. Bottom line is immediate loading can be done if they can get initial stability of 45, what's called 45 Newton centimeters. So imagine torquing a prosthetic screw if you're a lab or a restoring doctor. The surgeons have their own surgical torque wrench or electronic devices, but they can check the initial stability. So how tight is it, right? If they get a certain measurement of stability, they can put a temporary bridge in out of occlusion, right? We don't want clenching on those during the healing phase. But once the bridge or the restoration from a single tooth to a full arch, as long as the patient is on a soft diet and they're not over functioning on that, the implants will integrate. They actually get softer after about 6 weeks, meaning they're less stable as the bone begins to remodel and starts going through that process. But again, it's very, very predictable. It's not new. It was done with teeth in an hour, or teeth at the time, teeth in an hour or teeth in a day. Those were done back then. So again, it's in the right patient, the compliance and the right drive from the patient, it can work very well. So then when we look at the difference between the guides, as I mentioned, the tooth-borne guides, we need the models. They're going to fit on top and they're going to be very stable. Edentulous guides require what's called a dual scan technique. So envision that we're going to take a CBCT scan of the patient, lower jaw or upper jaw, the denture in place with it in their mouth. We do one scan with the patient with the denture in their mouth. We then take the denture out of the mouth, and there's a second scan that's done of the denture on its own. So they're just digitizing the denture acrylic so that I have two sets of files. And we use markers then to line those up, right? So we're able to line them up in the software, and the markers themselves, sorry, I went back accidentally on a slide. The markers themselves are used to line everything up. And you can do it if you make a mistake and you didn't order the markers, you can just put a little gutta percha circles or balls into them just by using a round burr. Call us if you ever get into that trouble. Right. So on the edentulous workflow, again, we just need the right markers in place. And then when we look at, the immediate approach, as I mentioned, all on X or all on 4, all on X is what every other company uses as a term. The concept is more of a treatment concept, more so than it is a sort of a product, right? The thing to bear in mind is with any of these, it's a denture that's prefabricated. We've already done the work, essentially doing an immediate denture. They're usually patients that are dentate with a hopeless dentition. But you have to bear in mind that you do all this same day. So surgery done in the morning, and then you do the denture conversion end of the day. And my experience with these has been they work very well, but it's demanding on the office, right? You're focused on that one particular patient for the day. The other one is stackable guides, and that guide approach. I'll show you an example a little bit later. This is where everything is pre-done, and essentially we've printed out all these various jigs to be able to do the surgery, and then click on a jig holding a bridge. And again, you can do that pickup just like you saw earlier with that temporary bridge. The other thing to keep in mind is when you're doing just in time, this is one we actually see the most. And this is what I really like. So the surgery done on a Friday or any day of the week, the surgery is done in the morning. We get the scans in, but of course we've pre-done the case. We've designed it all in advance. We've done a smile design. We know what the end is in mind. The scans of the implants are done at the time of surgery. So right then and there, they're sent to us. And then all we do is merge everything that we've already pre-done with now the fit of the implants. And we mill or print a long-term bridge, right? Usually next day for those or 2 days, but we're definitely within the window of appropriate immediate loading. We're not pushing the limits of integration at that point. So again, you do it within a few days. And the reason I like this is you get a much more elegant bridge that's done because we're designing it to implants that are placed. We're not taking a denture, hollowing it out and grinding it up and leaving it bulky for strength. We can then really design a nice bridge for those patients. And it really, really works well, right? This being the stackable approach, think of it like a reduction coping on a tooth, right? You've got the bone reduction guide, and in that they're incorporated the magnets. So this is one that was done some time ago, right? Where you've got the bone reduction jig. So again, just like a reduction coping on a tooth, you can level down the bone. You then click on, and it's just magnetized. You click on then the surgical guide aspect where it's got the guide sleeves. But then we also have another one that then clicks on, but it actually holds the temporary bridge. So you can use that to then position everything and be able to lute the temporary cylinders in place. Again, like I shared before, not everything is done as, finished, right? You need to do the dentistry to be able to relate them. So back to the dual scan technique, this is what it looks like with the markers. And again, it's just to help us line it up in the software and to match the two. So you see on the left, the scan of the denture, and then replicated, we see the markers that were in the denture while in the mouth at the same time, and it all gets lined up, right? Suremark is the company. I think Henry Schein has these. Patterson does. as well, but it's just a tape on a roll, and you peel them off, you stick them in. They're for other medical procedures as well. There's varying types that are done, but it's really just to give you that alignment, right? What we don't want to see is what you see on the right, right? We don't want to see radiopaque teeth or, utilizing other sort of gutta percha aspects. It's great for visualization of the positions, but it doesn't give us any alignment capabilities. So what we want to see is what you see on the left, where they're just round markers, again, the sure marks or the secondary ones. So when we move on to the software, the nice thing with Exoplan, so I've been working with a number of them over the years. I was fortunate enough to work with Noble Biocare when Noble Clinician was introduced in the early days. And the biggest challenges in the early days was we didn't have the computer power. But as I say, this is just obviously a rapid walkthrough. I'm going to walk you through a couple of cases. But with this, we can do the tooth design. We then get the protocol as well. Again, if the implant company shared it with us, and with Exocad or Exoplan, we then can give you the implant of your choice, place the implant virtually, and then provide that report. So we can actually determine as well, we can use different guide sleeves if you have your own preference, or for whatever reason, say they're back ordered or there's some challenge. There is other sleeve companies out there that are considered compatible and often approved by the other companies, or they work with them themselves, right? But we can do immediate extractions. We can do all the editing we need to do for the case, so we know what that final case will look like. And then again, in this case, it's fully edentulous, and we can work off of a model and be able to produce that. But then again, you get both an implant plan report, and then we also once we create the surgical guide, we'll provide you with a surgical guide report. So when we look at a case as we receive it, once the case comes in, we've digitized everything, right? We look at the DICOM, make sure it's usable. In some cases where the patients have a lot of restorations, there's a lot of metallic artifacts that are present. Sometimes we can't see the teeth. I've seen bad ones, but by and large, certainly locally, we've had a good experience. So this is just setting up what's called the reslice curve, so that I know that I'm able to see when I'm in the sinus or what have you. They're not always automatic. So then we take the scans of the model, just click on a few points. Right, we get the initial alignment. So this is not perfect yet. This is just putting it in the orientation that we want. Right? We've had scans that were the wrong scans that were sent to us as well. So you got to make sure, obviously, that everything matches. Next thing it'll do is it'll automatically align it. So blue is cool, right? That's a good sign when everything is lined up, right? So we can either do manual adjustments at this point, but really what we want to do is we want to scroll through the scans, and we want to make sure that that model matches on the teeth. Right. I talked about the soft tissue before and the fully edentulous. You can't match it in the same respect. Right. So then we do our setup. All right. So just think of it like placing a denture tooth. Right. And I'm working in Exoplan here, but initially we can also go into Exocad, do the full restorative preparation and workup. The reason I like doing it this way is I can, in fact, import the plan and back engineer it back into the model and create a master cast from it as well. So if you do want to have a provisional, based on the plan, we know pretty much where our expected screw trajectory is, and we're able to line it up from there. So then once we have everything lined up, just make sure. So then, as I mentioned, we have a full library that's available for all the current Canadian systems. There's always a little bit of digging with any of the new ones that are coming out, or patients that have been treated, in the rest of the world and they arrive in Canada. And this happens probably more often than you think, where they've arrived and we're trying to identify an implant. But we go in, we choose the system of choice. Again, just in this workflow, I'm using Nobel, but it doesn't matter. And then it's just an arbitrary choice. If it's a lateral, we'll choose a narrow implant. And then we do our initial placement. And then we start working on the reslice curves that you see on the right. And again, just like you would do on various x-rays with overlays and in your implant training, this way it's the same. It's the same dimensions. It's the same STL, in fact, of the final implants. And then we identify the position, make sure that we're restoratively driven, right? We're going to have a screw access hole we can actually use. Right. So you see in this case, the positioning looks all right, but I'm not sure about the tooth roots. Right. So once we've done our position, we work through the reslice curves, we have a look at everything in the position of the implants, then we send you the plan. So once you've received that plan, you'll have a look. And again, it's a PDF. We also do quite often, we do live reviews. So we can then go and do a web meeting just like today on your case, and then we can review it. But in this particular case, the patient had a pretty good opening as far as the lateral position. There was lots of room. We were able to fit everything in, but we'll generate the implant plan for you. And what that'll create is the step-by-step. So it'll give you an OPG view, as they call it. Once you have that view of the case, right, you'll see, again, the OPG view, which is not a panoramic view per se. It's actually where I set that reslice curve, but it'll give you an idea of the overall situation. And then as you scroll down in the report, you'll get the individual implant sizes that were planned, as well as a per implant breakdown of the positions. So what it gives you is it gives you the position of each implant, and it'll give you at center of implant, as well as stepping along the arch, 0.6, 1.2, as you go forward and back from the implant, as well as palatal to labial on that as well. Right. So the report gives you, sort of a multi-slice view, again, generated from the program, but it's using the DICOM slices that are provided and gives you an idea of the proximity, obviously, to vital structures or any other decisions that that are required for the case. Right. And then once we have that plan ready to go, we can then go ahead and generate the surgical guide. Right. So all we're doing here is we're just creating a surgical template with enough material around the sleeve so that it doesn't break or doesn't pivot on you. Obviously, we want to make sure it's substantial. And this is just the final step where it blocks out the model. So think of it more at this point, just like a night guard or a splint, where it's just going to, like, waxing it out, if you will. It virtually waxes it out. And then we set up the surgical guide design. Right. And we can do, we do framework types. This, again, being more like a night guard, just fits over top of the teeth. And then we'll give you some windows in it as well, so that you can ensure that the surgical guide is seated down on the incisal edges of the teeth. This will just take a minute to generate the guide. Right. Then we can add in windows. As I mentioned, we just give you some windows to make sure that you can see everything. Right. And then we generate the surgical guide. So once it has all the parameters, the windows that we want and the supports that we want, then we just thicken it up. Again, we just want to make sure it's substantial enough that you're not going to have any pivoting, twisting, or any fracturing. There's nothing worse than a surgical template you can't use. And that's what the final surgical guide looks like. So again, in this case with the lateral, we were able to do fully guided. But if the spacing was tight, we could use a pilot sleeve and then be able to, you would be able to then drill with a 2 millimeter drill, your initial drill, and then you would prepare it with traditional drills after that. In this case, we're fully guided, so every step would be done with the surgical guide in the mouth. Right. So again, the surgical guides are generated, they're lined up right when we're doing our scans, and then all that becomes integrated, if you will. That file is utilized. We do the final plan and integrate the sleeves into the final template. So from a standpoint of sending it in, what we're requiring really, as I mentioned, just as a reminder, the CBCT data, the intraoral scans or models, or conventional impressions. We'll pour them up and scan them. Diagnostic wax up or the restorative plan. What is your plan, and what surgical kit that you're working with as well, so that we ensure we're using the right sleeves and have time to order them if they're unique, and then determine whether you're doing immediate loading or what that provisional plan is. And really, that's what we need to know from that perspective. So once we have everything we need, we'll design it. And usually we ask for a few days, probably 3 days to do the turnaround time, and then 5 days for the printing, just to make sure we have everything. Sometimes we have to order in the sleeves, but usually we know that when we're doing the plan. All right. And then finally, sterilization of these guides. They're primarily cold sterilized. There was companies working on milling them and using other materials that you could properly sterilize, but they will distort. It is really just a splint resin or modification of, but you really don't want to heat these up too much. We don't want changes or anything like that. Bear in mind, you want to try in those trial drill, the spoons, try the drill guides into those sleeves in the template. You don't want to find that out right away, day of surgery. Open up the kit, check them to make sure that when the patient comes in, everything's going to fit well. That's the last thing we want, is we find out after that you're unable to use it. All right. So on that note, I do want to thank everybody for joining us today. If you have any questions, any planning discussion, reach out to Mark or myself, and we can certainly help you get set up and ready to go. Thank you.
Okay, Kev. Thanks a lot, Kev, for that presentation. That was fabulous. We do have a few questions, and again, if you have any other questions that you think of later on, you can contact us at the lab, and we can field those questions. Again, Kevin, excellent presentation. You do it so smooth, but your knowledge is it's all there. You know it inside out, it seems. I got a few questions. Some of them are for the, from the lab's point of view, like as a lab, we, the lab, Rotary Down Lab, provide the surgical kits?
Yeah, good question, Mark. The surgical kits, they vary. They really do, and we're not a distributor of those surgical kits. They would come directly from Straumann, Nobel, Hyacin, whatever company you're working with, they will provide you, sell you the kit. They rarely lend them unless it's a trial of a new system for you. But no, and usually the drills are single use as well, so that needs to be ordered. When it comes to the sleeves, we take care of that portion of it. But no, you will work with your implant company for any of the unique or specific implant components.
Okay, next question. Oh, here's a good one that we've discussed. I think it was last week. In Exocad, are the libraries from the implant companies regularly updated? I guess they're meaning like when the cases come in, or when an implant company updates their implant library, it's automatically done in Exocad, not in the Exocad library. Where do you find?
Yeah, good point. Good point. And I mean, this, if you're an Exocad user that's on with us today, or Exoplan potential user, the libraries themselves are regular. They're updated regularly. And if you're a lab that's using Exocad, the thing to bear in mind is there's a download manager or a library manager that's important to utilize rather than copying and pasting folders. Not to get in the weeds, it's just important that you don't transfer old mistakes. The library manager actually removes what companies have dictated to be removed, and they've brought in the latest. But it takes time. It can take 2 or 3 months for an implant company to give Exocad what they need that would then populate the library. We usually know, the unique ones that would be in that situation, like a company merger or something like that. So no, the best thing to do is go in, download whatever specific companies. We have them all that are available in Canada, but you want to check them from time to time. And the nice thing is the software will tell you there's no sleeve available, right? Or it's an unsigned library, which means that it's an older library where, maybe they've discontinued the sleeves. But then the nice thing with Exoplan is it gives you alternatives. Steco, which is a supplier in the US that Zimmer uses for the sleeves, in fact, or for Exocad, generic sleeves. And really, it's the diameter that matters for the drill guides. So keep that in mind. Good question.
When doing a surgical guide for complete edentulous cases, would you do a acrylic reline of the denture if using original before the CBC? I guess for the accuracy of the fit in the mouth.
Yeah, good question. And yes, ideally, yes. If and again, it not as a soft liner. So do the reline, do it as a harder acrylic reline to be defined there, and then because it doesn't show up if it's a soft liner, all you see is the trimmed back denture. So yeah, but ideally, yes, perfect fit or ideal fit is always better than the surgical guide will fit that much better.
Okay, and you mentioned a patient without a denture, and would it be advantageous for those types of patients that are going to the surgery guide to actually make them a reference denture or something like that we could put in, just to give us an idea? Would that work, or would you just recommend making a denture first?
No, absolutely. I mean, there's no making 2 dentures. We can do part of the workup. So if we get the bite blocks, we get it to the point of a try-in with the patient. We can then duplicate that in clear. So we actually keep, the setup aside, but we can actually produce that denture just in clear acrylic with the markers. And that way, same as the denture acrylic, it works the same, fits well. We've got everything we need. And that way, then we've also got the setup already ready for whatever we're going to do as the definitive prosthetics.
Okay. For implant, when doing implant planning for surgery, can a remote conversation be done, like for the initial overview? And would that be live that the doctor could say, or the surgeon say, adjust this, do this, or we have to look elsewhere?
Yeah, good question. What we do is the initial communication, once we collect everything, get all the stuff together, we'll do an initial plan, and then we'll email it to the referring doctor, whoever has contracted us in that regard. If we know who the surgeon is as well, or have the email, then we'll add them to the email communication. We do a secure share of the PDF of the plan. And again, this is the initial back and forth conversation. Oh, I'm not using Straumann, I'm using this, I'm using that. I'm using a different kit. Then we do a live review if needed, depends on the case itself. And the more you do, the less one-on-one has to happen, I find, because we sort of know what you're working with and we get used to each other in that respect. But yeah, the web meeting is just like this, where we log on, we pull on the software, and we're able to do it live. And we can come to the office if it came to that, but a web meeting is usually enough to show 360 view around every implant, and understand that aspect of it and make sure we're safe.
Okay. So what's the turnaround time to receive a plan once you have all that information from the doctor's office?
No, good question. We need to get everything on our hands, to grab all the photos together, bring everything together. We look for a minimum of 3 days before we'll get you a plan. Obviously, we'll accommodate something quicker just so you have a good turnaround time. And again, what that is an email of a PDF so that you have the initial thoughts on what we see we can do. And then, of course, there's a bit of back and forth, and then we can do a live review from there. And then the surgical guides, we ask for 5 days from the thumbs up. We're gonna go forward with it to the point where we'll print it out again, QC everything, make sure there's everything's fitting properly, and get it back to you.
Okay. We'll do this last question. When aligning scans, I think this is where this question's going. When aligning scans, is the intraoral scan the same accuracy as a CBCT scan, or is there slight variations from one, like each scanner?
Oh, great question. Yeah, there is the alignment itself, right? There is differences when it comes to the surface mapping, especially if there's a lot of scatter on the teeth, right? But it does acquire or lines it up, which is why there's a visual inspection. Some of the planning programs, and we use others. We use Noble Clinician, we can use Co-Diagnostics, which are all fabulous. But some don't do that as an automatic process. Some make you do the alignment. They don't want it to be an automatic process because they don't want the program to make the decision. They still want you to do that. There is a variance, but it's as good as what CBCT is considered today. If you're a CBCT user, right, there's slice thicknesses, there's the sequence of slices, the intervals that can affect the accuracy. Again, we can only get so close with a slice thickness from one slice to another. So to your point, how accurate is intraoral scans? That's a debate in and of itself. We see a lot of variations in that as well. It's as close as we can get, given the current technology. Maybe we'll get closer. There's discussions of LiDAR and other techniques, but no, at this point, we're as good as we can get. And I can't quote a number. I think there's some studies that compare it, obviously, but it's more comparing the variances in the CBCT. At least with the model scans or intraoral scans, we're at least at the standard currently.
Okay, one last one I snuck up on me. It's like with the surgical guides, what's the most common surgical guide that we see in the lab?
Oh, great. Yeah, good point. I started off talking about the prosthetically driven guides, the vacuform type, or, we'll pour them up with sleeves in them. As I say, we do those every day, which is great. But primarily what I see from a planning perspective is one or two teeth. We're seeing more and more full arch. That may just be relative to our market here. It's not that we don't do them. We just don't see the demand that much. So I would say most commonly it's a single tooth pilot or fully guided or two or three teeth where we're seeing the guides being used. Also very posterior mandible a lot, obviously for safety reasons and wanting to identify all the vital structures. That's very common as well. But we tend, I say this, but I'm doing one now with 6 implants. Just every day from a more common perspective, it's really singles, short span bridges that we're seeing the surgical templates being done for.
Okay, great. Kevin, thanks a lot for this. Lots of great information. Again, this is recorded, so we'll have all this recorded, and it'll be on our website probably within a week or two. And again, if to the people that are labs looking at Exoplan, we are resellers of Exocad. That's the Emerald logo here, and we were the original resellers of Exocad. So we've been in this industry for a long time. Exocad, traditional, crown bridge, dentures, all that stuff. We have great knowledge in that, but also with Exoplan, and Kevin's a great resource in this area. So again, Kevin, thank you, and everybody else, thank you for participating in this, and have a great day. Take care. Bye now.